So, as most of you know that are showing up, because we got a nice crew coming, Jason Peterson, Chemical Threats and Biomonitoring Supervisor, and Brianna Giles, Chemical Threat Preparedness Coordinator. That's a huge title. I need a title like that. It's long. So they'll be speaking here shortly. After we get done with these, we'll turn it over to Brianna.
Okay, this is a new slide. We just want to elevate your cases for folks that have boots on the ground, so to speak. So if you have any interesting cases that you feel the group would benefit from, learn from, please feel free to reach out to Katie and share those cases so we can disseminate that information amongst the rest of the attendees.
All right. Just know that, we don't always have the answers. So you might go, yeah, I don't know what to do with that either. So we got a lot of great stuff coming up. Pharmacists' involvement in opioid stewardship and addiction. Natalie is down in Olmsted. That's going to be a wonderful talk. About a month from now, we're planning on doing a little 7-hydroxymetragenine case and a little review on that because it's just been huge here in St. Cloud. We're probably seeing 3 to 4 new patients a week. So, and then my favorite person, Andrew Baker, coming in March, which he's always extremely interesting and fun. So, all right.
Technical assistance, keep in mind we are here for you. If you have any questions on policies, protocols, operations, workflow, patient cases, don't hesitate to reach out.
All right, just this is a new slide as well. I just want everybody to know that April 30th from 9 to 3, Dr. Perringer and myself, and with some help from Erica Bergraff, one of my nurse practitioners working here, and Alex Stalmakov potentially will be hosting this addiction medicine boot camp. It is going to be a buprenorphine day, and it's going to be lots of cases, probably 2 to 3 hours of different cases, both clinic and hospital. So it's free, and it's free CME. Let me say that one more time. It's free. You can come here free and do this 6-hour training. So please feel free to come. I think it's going to be great. I think most of you probably have seen Dr. Perringer speak as well. He's 10 times smarter than I'll ever be. And so it's going to be really fun to kind of have him down here in St. Cloud doing that. If you have any questions, just please email me or Brittany Goebel if you want to register. We've already got a lot of people registered, and we're going to take up to 100 people. So next slide.
Just a reminder that Stratus Health is the home to the core website, which lays out sample policies, protocols, and informational handouts on MOUD programming. So don't reinvent the wheel. Check this out first.
Ooh, Zoom polls. And just remember, everybody, you can also feel free to turn on your video. We'd love to see your beaming faces, and I'm sure Brianna would like to see them as well. So feel free. Which of these best describes your role? Provider, nursing, pharmacist, behavioral health, or other? Some others today. It's you, Aaron.
Oh, am I supposed to read it? All right. As part of your role, please select the applicable multiple choice answer.
All right. And let's see what the final is on that. I think Katie's just sits and counts these really quickly. All right. Most people are actually working with patients, so fabulous. All right, with no further delay, let's get our speaker on, Brianna Giles. She is going to tell you a little bit about what she does in her real life job, and then we're going to talk about her real life statistics. So feel free to take over. And I don't know if you were planning on sharing your slides as well.
Yes, I will share the slides. All right, let's see. Are you getting the whole screen or just the presentation?
I'm just getting you with the presentation. The presentation is pretty small. It's the
Okay.
same size as the picture of your picture.
Content only. How's that?
There, that's good.
All right, great. Yeah, thank you for having me, everyone. My name is Brianna Giles. I am the Chemical Threat Preparedness Coordinator at the Public Health Lab with the state Department of Health. So I'm going to be talking today about what we do at the Public Health Lab, and specifically focus in on the drugs of abuse testing. I believe Jason did hop on. He can kind of man the chat, answer questions, and be kind of available at the end. And yeah, we'll get going. It's just kind of an overview today inside the Public Health Lab, kind of all of our capabilities, focusing on drugs abuse testing, and then looking at some of the data that we're seeing, and then briefly kind of where we're trying to go with our drugs abuse testing. So if we think about the public health laboratory, most people are going to think about COVID, thinking about diseases in that type of setting. And, you know, we do a lot of testing with that. We have an infectious disease testing section. We have a team of epidemiologists that do a lot of contact tracing, you know, working, you know, with people that may come into contact with any type of infectious disease, foodborne illnesses, or chemical threats. But really, we do provide more than just that. We do provide 24/7 all hazards testing and consultation. And so our main role is really to prevent, investigate, and control disease and evaluate these public health threats. So we're part of the laboratory network for both chemical threats and for biological threats. We also have a radio chemistry program and a radio chemistry emergency preparedness program because we do have the nuclear power plants here in the States. We also do newborn screening. A lot of what I'll talk about today is going to be focused on the biomonitoring. We do a healthy kids program where we're testing urine of kids throughout the states, looking for, you know, 70 to 80 different compounds that they could be exposed to in the environment. Part of that biomonitoring does roll into this overdose surveillance, which I'll focus on a lot today. Again, a lot of drinking water, wastewater, emerging contaminants as well. We've been testing PFAS for a long time. So thinking about the Laboratory Response Network, this was something that was formed back in 1999 as a response to the sarin attacks in Tokyo, where we realized that we weren't really set up to respond to large mass casualties for any type of chemical, biological, or radiological incident. So with these sarin gas attacks, the hospital systems were overwhelmed. There wasn't a good place to get everything tested. People that were being treated didn't really, you know, some symptoms were psychosomatic, some were authentic, but kind of making that determination for hospitals was just not feasible. So here developed the Laboratory Response Network that's coordinated mostly by the CDC to kind of standardize methods for responding to these incidents. So there's a group of laboratories where we all will run the same types of tests to respond to these specific incidents, but also to respond to any unknown substance. If anyone's aware of, you know, what's going on currently in our state, you know, there are going to be incidences where there's going to be unknown things that are involved where we can provide that type of testing. So whether it's a small, you know, one person exposure or a large mass exposure, we're set up to do that type of testing as well. So when you kind of look at the chemical threat side, this is how the structure is set up here in the US. So there's level 1, level 2, and level 3 laboratories. So level 3 laboratories are going to have your lowest level of capabilities, typically don't perform very much testing at all, but can respond to events, have samples collected and sent to their laboratory that then they can package up and then send to other laboratories that have that testing capability. So level 2 laboratories are going to have some testing capabilities. And then level 1 laboratories are going to have the highest level of capabilities and then can provide that 24/7 type response. So we are one of the 10 level 1 laboratories. And the way that kind of works, if you think about, an incident where you had maybe 5,000 people that were exposed, instead of having one laboratory do all 5,000 samples, you could activate the network and have the 10 level 1 laboratories each do 500 samples. So you can get through those samples much more quickly. In most cases, we're talking about clinical samples, so someone that was exposed, and if they had any urine or blood that was collected as a part of their treatment, those samples would be collected from the hospitals and then sent to the laboratories for testing, and then spread through the network so there's more even distribution to make sure that we can get these testing out as rapidly as possible. We kind of practice that on an annual basis, getting an influx of samples, 10 a.m. in the morning, and we're working around the clock for the next 24 hours to try and turn those around as quickly as possible. This is just kind of looking at some of the chemical threat agents, what their signs and symptoms are, what those potential agents could be, what kind of lab tests that you might have on site at the hospital that could give some indication. We like to provide this to all of our partners just to get an idea of what they could be seeing with these unusual cases. So obviously, if you're seeing something that you're not sure of, and you're in good communication with the Poison Center, we have a very good relationship with the Poison Center as well, so we can usually get looped in, but you can also give us a call as well. We're seeing these types of symptoms, nothing showing up on our test, we have some residual sample left, can we get this to your lab and get some testing done? And so you'll kind of see how this works in conjunction with the overdose testing that we do, because if we have a relationship with the hospital, with the lab staff, with ED staff, we'll kind of already have a system in place to fill out our forms and get samples to us so that when these incidents do occur, it can be easier to get those samples. So looking at the drugs of abuse testing that we have kind of 3 different programs that we're looking at. So we have Mendoza, so that's the Minnesota Drug Overdose and Substance Use Surveillance Activity. So that is working primarily with hospital partners where they are flagging cases in the ED that are a result of overdose. And any clinical samples that are taken as a part of their treatment are then kind of held and flagged and then sent to our laboratory for testing. The other one is MinTest, so that's the Minnesota Timely Emergent Substance Testing Program. That is working specifically with law enforcement agents. And so if there are cases that are related to an overdose but are not being charged criminally, because those would go to the crime lab for testing, they can connect us with the hospital that the person was admitted to, so we can get a clinical sample. They also might have collected some type of product, whether that's a pipe or a bag or the actual powder or crystal material or plant material or whatever they potentially consumed. And so we could get both clinical samples and product samples to be running the test. We also kind of have a bigger drug product surveillance project that we are working on with harm reduction sites, where people can go to syringe service sites and give a portion of a drug to them, and then they can send those to us. That's just the product samples. So kind of looking at all these samples together, we do testing with a liquid chromatography high resolution mass spectrometry method. And we currently have over 1,300 different substances on that panel. So when you think of the types of tests that can be done at a hospital, you're going to have some panels that you can run, maybe doing full toxicology, maybe just some immunoassays. You're only going to have a narrow range of compounds that you're looking for as these new and emerging substances are coming out. The xylazine, the medetomidine, carfentanil, other fentanyls, BTMPS. These new and emerging substances that aren't going to be part of those panels, we can add those to our panel. And so we're able to capture that information as well. When you think about the product samples and you think about tests that are done in the field, those, might be very sensitive, but they're not necessarily going to be specific. You have a fentanyl test strip. If that turns positive, it's not going to tell you whether there's fentanyl or carfentanil, parafluorofentanyl. They have different cross reactivities. So it's not going to give you that full picture. So this really does, working together with all of these different projects really does provide a good picture of what you can see. When you get the clinical sample, you only are going to know what was in that patient's system at that time. When you get the product sample, you might know that last substance that they consumed that put them in that overdose state. So pairing all that data together, which I'll kind of go through today, is really what we like to see from this type of project. So I kind of summarized this already, but this is kind of the details of Mendoza. It provides that definitive identification of substances, specifically for non-fatal overdoses. Some patients do fall into that overdose death category, but in general, we're looking at patients that are non-fatal. We are supplying all of our partners with near real-time data. So it takes about 4 to 6 weeks to turn around samples. So we're not looking at something to be added to a patient's chart to inform their treatment. It's really to kind of understand what the drug supply is and being recognizing signs and symptoms for that next person that comes in. You have a patient that presented with XYZ symptoms. Oh, this is what was in that patient's symptom. They thought they took heroin, but it actually had fentanyl and xylazine, and they also were on meth. And they also had some THC in their system. So you can kind of see that bigger picture of what's in there, as well as anything that was potentially detected that was administered, will show up as there as well, plus any over-the-counter things that they may be on. We're going to get that full panel. And so it does help monitor cases and improve patient care. And we could continue to enhance our partnerships and share this data on a monthly basis with many of our partners on a quarterly basis. And just as new trends, as new detections come up, we're constantly trying to provide this data out to our partners and, in presentations like this to help our community. So just thinking of the program impact, what we really like to hear is, back from the clinicians, how does this program help you? How does it provide information for your patients? And this is, some information that we really take is, that conversation to have, with your patients. Like, you don't really know for sure what you took. You think you might have taken this one thing, but it's very likely that you probably took something else. It's very likely that might be a polysubstance. There might be more than just what you think was in there. And so just kind of having that awareness that you can provide to your patients, that you'll see in the trends from the data. A lot of trends are pointing towards a very high polysubstance use. So MinTest again. It's a partnership with Overdose Response Strategy and law enforcement agencies. So again, product samples and clinical samples from overdose events. It's kind of an example of kind of what results look like based on the situation, the significance, where the substance was found, what was in the substance, and kind of the significance of the combination of substances, whether it's a new detection or a new combination of things that we're seeing, or for seeing like, hey, we're seeing purple fentanyl. Purple fentanyl in the cities looks the same as it does, up in the Northeast or, in central Minnesota. We're able to kind of figure out those trends as well. And so, we're partnered with a handful of public safety agencies for this project. And then the product testing, surveillance, working with harm reduction sites. They'll provide some presumptive testing on site, and then we'll provide that definitive testing at the laboratory. We've really expanded the project over the last year and are starting to see a steady increase consistently of samples, and we hope to continue to grow that. And again, this is just that product testing. All right, so looking at the data. So specifically for Mendoza, if you kind of look at samples up through end of last year, we've increased our samples. Almost 6,000 cases have been submitted, and about 25% of those have had toxicology samples that we have tested at our laboratory. So quite a few cases that we've been able to see since the program started in 2017. So one of the pieces of information that's really interesting is really what the patients think they took and what the testing shows. So this is just kind of broken down by categories to just kind of see suspected versus detected pretty much in all cases, a significant discrepancy between what was suspected and detected. Looking at fentanyl, 21% suspected, but over half, 56%, were detecting fentanyl. So whether we're seeing fentanyl mixed with other things, or we're seeing just kind of a wider range of fentanyl products. That's really good data that we're getting here. Amphetamines, there's a pretty high gap there. Marijuana, in most cases, when you have someone that's come in an overdose state, marijuana is probably not going to be something that is listed as a substance that they took that's probably contributing to their overdose. But just kind of shows that almost half of these samples do have some type of THC present. And we do detect THC as well as like the carboxylic acids. We're looking at Delta-8, Delta-9, Delta-10 as well. So polysubstance, it's consistently increased since we've really been collecting this data. A little bit of a decrease is really only due to the wider range of samples that we started to collect. We used to have a very narrow range, kind of for criteria where cases would qualify, where they had to kind of have a specific checklist of things. But we've kind of broadened that. We've worked with different hospitals to kind of narrow in their criteria that's really unique to their hospital. Overdose in a small community, out in West Minnesota is going to be very different than an overdose that they're going to see in St. Paul or in Hennepin County. So changing that criteria did kind of widen the range to where we're not seeing as many, but still quite a significant amount of polysubstance. And in this case, we're talking about categories. So methamphetamines, cocaines, benzos, we're not looking at, each type of fentanyl. If you see fentanyl and carfentanil, that's still a polysubstance, but that would still kind of be in the category of fentanyls. So it's really, when you think of substances, it's going to be, sometimes we're having dozens of substances that we're finding. So it's not just 2 or 3 substances, it's kind of that category of substances that we're looking at. So kind of looking at one case in particular, where you can just kind of break down the data and see the different types of substances that you can see. So this is for one patient. This was 3 different samples that were collected and sent. A blood on one day, and then a blood and a urine 2 days later. So 18, 16, and 28 different compounds that were detected. I have it broken down kind of in categories. So at the top, you'll see all the kind of fentanyl-related compounds. So you're seeing fentanyl, 4-AMPP, so, the importance of seeing something like 4-AMPP, that really shows to us, that that's a clandestine manufactured fentanyl. That's not going to be from something that was legitimately made. So it's useful to see things like that. Parafluorofentanyl, orthomethylfentanyl. Those are the 2 fentanyl analogs that we're seeing very common right now. Cocaine-related compounds, methamphetamine-related compounds, other opioid, heroin-related compounds, bromazolam. So we've seen some benzos, seeing the medetomidine and xylazine, and then kind of those adulterants that we've seen there. So with these clinical samples, seeing something like lidocaine may not really stand out as a clinician. Lidocaine could have been administered. But when we look at the product samples, lidocaine is actually something we see pretty consistently in white powders and fentanyl samples. It's widely used as an adulterant. Acetaminophen, diphenhydramine are also often used. So whether that's something that they consumed as part of the product, part of the drug, or whether that was administered in the ED or just part of regular medication that they're taking. We don't necessarily have all that picture, but we do sometimes have those clinical notes then. So we do have a team of EPIs that work with the data, work with the hospitals, and are able to extract some of that patient data. So you can kind of get that whole picture of, okay, what was this patient on, what was administered, and then what did the lab find? So focusing in on xylazine and medetomidine, we put out a HAN last year as we started to see a really rapid increase of these substances over the last 2 years. So xylazine was first detected in 2020, and then we added medetomidine to our panel late in 2024. And you could just kind of see like xylazine consistently rising, did start to fall when medetomidine hit the market, and that really grew. We saw a rapid increase in the medetomidine detections, and that seems to be consistent so far with the few samples we've tested this year. Carfentanil. Carfentanil has been around for a while, but it did kind of go away for a little bit. We didn't really see it in very many cases at all for the last several years, and then started getting detections again in Mendoza in 2024, and then just a bunch of cases last year. Also, consistent with the product samples, we did get our first detections of carfentanil in the product samples last year. So just kind of being aware that that's something that is resurgent. And when you think of the strength, carfentanil versus fentanyl, significantly higher potency than fentanyl. So kind of looking at the powder side of it, if you look at these white powders, they're all fentanyl and carfentanil samples. But looking at the other compounds that we detected, you see some differences and some similarities. So, really important to consider, if you're communicating with patients being, oh, this is a white powder. This is, very similar to something I've used before. I expect it to have, fentanyl, expect it to have carfentanil. Well, here's all the other things that you could be having too. Heroin, parafluorofentanyl, xylazine, medetomidine, cocaine, methamphetamine, lidocaine, diphenhydramine, BTMPS, gabapentin, acetaminophen. Just a wide range that you see. So these are samples from Minnesota. Some of them are from the metro area, and then some of them from outstate Minnesota. But I think it really does show that there is that polysubstance there. You're seeing opioids, you're seeing stimulants, you're seeing, the sedatives, and then things like BTMPS. This was something that we've kind of noticed, kind of following the chatter throughout the whole country that kind of popped up in the East Coast last year. It's here in Minnesota. We don't know why people are putting it in the drug supply. We don't see it in clinical samples. We really have no idea of how the body processes it. There's some speculation that maybe it's part of the manufacturing of fentanyl, now that they've been controlling different precursors, that this is something that they could be using as like a byproduct through some type of production of fentanyl, but we're not really sure. But those weird things that kind of pop up in the drug supply, we don't really know how that's going to affect you. But it's here and we can see it, but we don't get that from the tox data. You do get that from the product data. So it's really useful to kind of pair these programs together. Looking at other white powders. So this is just looking at just variety. So some have carfentanil, some don't. Some have some of the additives, xylazine, medetomidine, just kind of showing the variety that you're seeing with the fentanyl sample. And that it really is this polysubstance that we're looking at here. So now kind of looking at brown tan powders, the same type of story. You do see a different combination of compounds here in these 5 different samples, all appearing visually to look the same, but a very different makeup of what they're having in there. Some with sedatives, some without, different types of adulterants in there. You're seeing some methamphetamine, tramadol, metafluorofentanyl, ketamine, just very different combinations. So, fentanyl isn't just fentanyl. It's a lot of different things. That's really the message that we get from these samples. When we get a suspected cocaine sample, it's typically just cocaine. If we get a suspected methamphetamine sample, it's typically just methamphetamine. But when we get a suspected fentanyl sample, it most likely is going to have fentanyl in it and a lot of other things as well. So this is just looking at one sample. This was a gray powder, so there were 31 different detections. I've just kind of highlighted some of the main compounds to look at. But this is kind of just the breadth of what we can get with our method. You're getting lots of different fentanyl-related compounds. So like that 4-ANPP and the other compounds, that's going to be related to the production of it. Some byproducts, sometimes we'll see those like metabolites in clinical samples. We'll also kind of still see those in the product samples as well. Heroin-related compounds, the sedatives, metanidazine. We don't see nitazines as often here in Minnesota, but they do kind of pop up. The metanidazine is the one that we will detect most frequently. And then just kind of looking at the wide range of adulterants that are in there, So when we're seeing these things in clinical samples, it could be from the drug that they consumed. It might not be something else that was, administered or was taken over the counter. That vitamin E acetate, which we'll see on this sample too, that's typically something that we see in like THC related samples, which really just speaks to the multi-use of the containers for these product samples. So, if someone uses something, empties it out, they might put another product in there. And so it's not like we see THC and fentanyl as like the same thing put together, but if they're reusing bags and there's that contamination, you will kind of see those fentanyl related compounds and those THC related compounds together. And while that might not have like a clinical impact on the person that's consuming it, if you don't know where that bag has been before, it's very likely that another substance that had a whole different set of compounds could have been in that bag and could be getting into the product that's being consumed and then getting into their system. So this was a residue. This was actually a ground score, so something that someone just found on the ground. So this had 48 different detections, really just a little bit of everything, and things you wouldn't even expect to see, the THC, the atropine, and a lot of things potentially came into contact with this bag. And so you can see how sensitive our instruments are, that even just something with a residue that doesn't even have a weighable amount of material, we're able to still detect quite a bit of substances. And so again, just kind of speaking to, you only know, what you're taking as good as who you're getting it from or where you're getting it from. There's a large range of substances that these people could be exposed to. So when you kind of put it together and we look at a sample that has biological testing, plus the powder product sample testing, and also like a paraphernalia device. So this was all related to the same case. So it kind of gives a larger picture when you can put it all together. So you know what was in the person's system, what was found next to them that was most likely the material that was consumed and the device that they used to consume the material. And you can see there's some alignment there. So seeing that fentanyl AMPP, seeing that cocaine and cocaine-related substances, the metamethadone, we didn't see that in the biological, which it could be a few things. One, it could not be part of the method, or it could just have not. It could just already have been discarded through their body. Depending on the half-life of things, depending on when the sample is collected, you might miss some things. And then just kind of seeing some other things in the body that aren't part of the powder or the paraphernalia, so that were consumed or administered at another time. So seeing something like this, when you have a device, the story that, I can kind of make assumptions about is, this is someone that, used something out of a device, The device had very high indications of cocaine and cocaine breakdown, and then also had fentanyl in it. So is that someone who used cocaine that also had fentanyl, or someone that used fentanyl that also had cocaine, or that intended to use both? It's kind of hard to say. My past experience, I actually used to work at the crime lab. I actually used to test a lot of drug samples, and so I've seen a lot of different paraphernalia devices. This device in particular actually looked like a cocaine crack pipe. So I would guess that this was a regular cocaine user that might have got a sample that had fentanyl on it as well. So that's just kind of the story that I can kind of assume. But you are getting more information, and it does kind of help build that picture of what we're seeing. So kind of summarizing the emerging threats that we're seeing here in Minnesota. So I touched on carfentanil, I touched on nitazines, heroin. Heroin is also making a resurgence. We hadn't detected any heroin since 2022, and then starting last year, we started seeing it again. So that is also making its way back. Spirochlorphine is something that has been chatted about throughout the country. It's been seeing a lot more in the product samples, primarily on the East Coast, but we did see it in a sample here in Minnesota. BTMPS we're seeing here, parafluorofentanyl, orthomethylfentanyl. Those are the two main fentanyl analogs that we see pretty consistently, both in the product samples and in the clinical samples as well. We just recently got some samples that had phenazolam, also known as clobramazepam, and then that ethylbromazepam as well as bromazepam. So these were counterfeit tablets. A typical benzo user that specifically sought these out and bought them actually out of states and brought them back here. And so that's just something to keep in mind too. So even though it might not be something that we're routinely seeing in our drug supply, it's out there, and so things that we're seeing on the East Coast, things that we're seeing in other countries, whether it's something's been controlled in the supply chain coming from China or Mexico, those trends can make it here. Sometimes it takes a little longer. Sometimes we're right on par with hitting these detections at the same time, but all these things can be popping up. And typically are popping up when you're not expecting it. And so, someone that, buys a benzo off the street is expecting alprazolam and gets phenazolam, gets ethylbromazepam. That's a unique finding there that is relevant and definitely useful to know when you're thinking about talking to patients and treatment. So kind of summarizing everything and kind of putting it all together, when you think about the laboratory response network, when you think about the biomonitoring, and then all of these drug testing projects that we do, they all really work together. They all kind of overlap. When we get these unknown samples, we're kind of utilizing all of these different methods to kind of build a picture of what could this be. We'll look at signs and symptoms, be like, okay, maybe this looks like a benzo, maybe this looks like a drugs case, maybe it's opiates, or maybe it looks like some type of pesticide exposure, or maybe it's a nerve agent. We kind of use all of our testing capacities. And so anytime, a weird case kind of comes through the ED and you don't really know what it is, things aren't aligning with your testing, with symptoms, with the narrative, we can be a resource, whether you're a part of Mendoza or Mintes or not. We can provide that expertise and hopefully find answers, on what was in this person's system. We can test blood, serum, plasma, or urine. We can also test the actual product samples. All hospitals have different policies on, when they encounter substances. But, if that's something that you can get your hands on and you can work with us, we can test the product, we can test the clinical, we can test both. It's all helpful information to kind of build that narrative and help patient care. I kind of talked about the 4 to 6 weeks turnaround, that's kind of for routine cases. When we have these emergency samples, we are prepared to be running samples overnight to get this faster. Depending on the type of sample, the type of information that we have, we can get information back 24 to 48 hours, or within a week. If we do have, patient care, that is going to be affected, to where we really have no idea what this patient is on, what's in their system, and we really need something that's going to, help us impact their treatment. That rapid testing is definitely available. So one case I kind of want to highlight that kind of puts all this together is a colchicine poisoning that we had a couple years ago. So we worked with Rochester PD on this and their ME on a poisoning death. They had thought the person had been poisoned with a smoothie. We ran the smoothie through all of our methods, weren't really able to get any hits. But then we did work with the ME and got blood and urine. And even we ran it through all of our chemical agent methods, didn't find anything. We also ran it on our drugs of abuse method, and we got that hit on colchicine. So that was very useful for the investigation. There was information that allowed them to make charges and provide that information. So we don't always work in capacities for criminal cases, but we still can. All of our methods are fully validated and do stand up in court, if needed. And so when you have these relationships, you have access to all of this testing and at no cost. We have funding for overdose surveillance, and we have funding for the Laboratory Response Network to do all this testing. So as long as you can figure out how to get the samples to us, we can really be a resource to provide lots of information for these cases. So kind of looking at future directions and kind of where we're going, our main goal is really to just increase our testing capacity and our coverage for the whole state. We want to have coverage in all 8 regions, and we want to just be able to be running more samples. So we're trying to get more staff trained and get more instrumentation so that we can run more samples and kind of get a higher throughput. And then we continue to expand our library. So as new substances kind of start to hit the drug supply, we are going to continue to add them. And one of the unique things we can do as well is once we add them to our panel, we can actually do a retroactive analysis on data that's already been analyzed and be like, oh, we actually did see, xylazine before we, put it on our panel. We actually saw it 6 months ago. It just wasn't something that we had in our library. So that can be done upon request as well if we're looking for trends. And then just exploring new partnerships. We work with hospitals, law enforcement and harm reduction sites. But we can explore different types of partnerships. If there's other ways to get us samples, working with EMS or working with other partners, we're definitely open to exploring that as well. And that's all I have. Yeah, I don't know if Jason has anything to add or if there are questions.
Oh, there's questions.
All right.
Yeah, somebody was asking about kratom and whether or not you test for that. I believe I've sent in for that many years ago, and I thought you guys tested for that, correct? Mitragynine?
Yes, yep. We do. Yeah, we test for the mitragynine and the 7-hydroxy.
Yep.
And we do see it.
Trying to answer some questions. Sorry I was late. I'm Jason Peterson. I supervise our chemical threats biomonitoring unit here at the Public Health Lab. Couple really good questions kind of came through. The kratom one was great. We do look for it. Is of public health concern as it is pretty readily available. Michael did ask a question if people weren't kind of looking at the chat about turnaround times. Bree had mentioned it for typical surveillance samples were about 4 to 6 weeks from the time we get it until results are issued. That doesn't always mean that it can't be expedited a little faster. That's just our typical flow for a surveillance level sample. Based off of our LRN activities, if there's an elevated public health risk associated with some issue like a poisoning you're looking at and it's an unknown and you've got maybe more high consequence patient that you need help with, there is potential for even more expedited analysis where we could call people back in a 24/7 capacity. Lab itself really just runs on normal business hours. However, the LRN activities we have allow for that 24/7 response. So those are in there as well, but it is kind of one of those ones where you'd have to call us. We'd be in communication. It might be bigger outside of the scope of what you're even thinking about, just doing patient care at that point. A good example would be we responded to a ricin incident on the University of Minnesota's campus in 2019, where hospital was focused on patient care. Due to the usage of ricin, which is a WMD style agent, it elevates it up pretty quickly on our end. And we call people back in, and we were here in the lab testing samples until like 3 o'clock in the morning. So those ones do pop up. They do happen in the state, and we are available to assist with identification of it.
Awesome.
The samples sending. Bree does a lot of that sample sending, so I can let her talk about that.
Yeah. So, I mean, always contact us before just sending us samples. But we have forms. So just a simple submission form. For anything clinical, we need two unique identifiers. So typically like an MRN or a date of birth. If you want to have something de-identified, even further than that, you can use your own numbering system. Sample 1, blood, just as long as it matches the form, matches the tube. So that's unique and enter in our system. That's really, all we need with the time and data collection. And then, whatever matrix it is. Each sample just needs its own form. For our testing, our method's very sensitive. So, we need I think it's only, 100 microliters that we use for each test. So, less than a mil is really all we need. Cold as possible is always best practice. So a lot of hospitals use courier services. So we have routine couriers all the time that come to MBH. So we're located in the Capitol Complex in St. Paul. So there's a lot of couriers that routinely come here all the time. Just kind of throwing something on there is usually really easy. There's also lots of other couriers that can be used. We do have samples that are mailed. I'm sure, most of you and lab staff have, know how to ship things on dry ice or ice and things like that through the mail. Or also just dropping things off. We get samples from regions every once in a while. They just bring it to our door. As long as we kind of have a heads up, there's really no limits on how we can get samples.
Perfect. I think that's all the ones that are in the chat. Is there other questions people want to unmute and ask? I know I have a couple, but if somebody wants to unmute and has other thoughts.
Dave, Kurt, I wonder if I could just kind of weigh in on the Mendoza component. Specifically, again, to echo some of the things or what Bree has already described, and just to sort of highlight, it makes sense that at least in the clinical setting, in the emergency department specifically, that do we really need real-time information on what's found in a urine drug test? And sure, it would be helpful, but you're treating the patient in front of you. So this is such an opportunity, I think, to really provide a more informed decision for clinicians with regard to patient care in the emergency department, even for patients who are coming in afterwards, and what's in the community and looking at trends, and so it can be shared with community partners. So the fact that if your hospital doesn't check for metatomidine or fentanyl or even that, this is an opportunity, I think, to gather information that can really help with patient care. It's, as you pointed out, definitive testing, unlike those immunoassays that a lot of us run. So we can take away the false positives. And then there's some quantitative information in addition to what you're seeing, the quality, the qualitative stuff. So if you are at a facility and they're interested in joining Mendoza, I think probably Bree can have them use your email.
Yep.
So, and you can see I'm biased because I have benefited from lots of the things that Bree and Jason have described with regard to the clinical care that I've been doing. So thank you very much for this work. It's great.
Yeah, we've actually used the lab a couple of times, and our ERs and hospitals pretty good about getting it down there by courier. We're trying to hook up to Mendoza. We actually had the lab director changed right when we were just about to get it going, and all of a sudden, it's like 6 months later. It's like, well, why aren't we hooked into Mendoza? It's like, so we're backtracking. but it is a great service. And in the cases that we used it, it's been fabulous. So other questions, anybody with any thoughts? I watch a lot of, a little bit of Netflix, and in Homeland, they the guy comes out with a sample of ricin or something like that, walks into the lab, and within minutes of handing him that test tube, they know exactly what it has. But that's not realistic, I guess. It takes a little time, but they seem to know.
It does take time.
Yeah.
As you get those ones, part of that, if you're thinking outside of the Mendoza one right now, right, that's a typical surveillance. We've got that one pretty well locked in on how we're testing those samples because it's become routine. The ones that are not routine, the conversations that we have with you guys in the hospitals becomes very important for us as we start to steer our analytical testing. I'm sure many of you haven't seen the capabilities we have at the public health lab. Bree went over them. They're pretty extensive in terms of compared to what other national or what other state public health labs have. So it gives us a lot of tools to work with, and sometimes a lot of tools slows things down. So the narratives we actually get from you become very helpful for us to steer our testing, which then actually expedites some of the results we can get back out. So it's not going to walk in the door, shove it in front of a laser that doesn't tell us anything and get a result. But what we can do is we can start to go through this paradigm of testing. And if we're lucky, depending on the narrative and some of the assumptions that we make on the front end, you might be able to get results on those emergency unknown samples within 3-4 hours. So it can still be pretty rapid. It just ends up being part of the narrative that we get. And if we get lucky on the choices we make on the front end, if we don't get lucky, then we backtrack, right? And then we go down different paths. And usually, we're in communication with you guys through the whole thing. And it becomes exceptionally valuable. We've seen it with the EVALI response. We were heavily involved in that one. So we were getting national information out and pushing information out back to hospitals. And we got a lot of samples actually from the St. Cloud area during EVALI, which was great because it was a very seamless process to do it. So we knew, as we talked to you guys with Mendoza, we knew how to get samples from your site to our site. Kind of have that in play already. And so it becomes really helpful in those regards for us to be able to get information, analyze it, push it back out to you guys so you can make, good patient care choices that hopefully help improve their outcome.
Cool. You talked a little bit about these harm reduction sites. Brianna, where are those in the city? Are they all metro?
So we have some metro partners and then some non-metro. It's just developed. So we just started this last year. So it's actually a project that we just provide testing for. So DHS is kind of spearheading it. They kind of have which partners they want to work with. So it's not just kind of an open enrollment that any harm reduction sites, but it's just kind of the same message. Anytime we have a partner that has some type of weird substance, we had worked with one of the sites before they even had joined officially, to where someone had a weird reaction and they didn't know what it was. And so we tested it, and I think it was just like CBD, but it was an unexpected reaction. So, when we're connected into the community like that, it really does kind of widen the type of samples we can test.
Yeah, and Beth could probably speak to this one. When you get into the Mendoza data, right, you really see how comprehensive it is. And it answers a lot of questions from a treatment side, but it also brings up a lot more questions of what is the usage profile to get these number of substances into their system, and what's the exposure route of it. Working with harm reduction sites through MinTest and law enforcement agencies through MinTest, it helps start to answer the question. And you saw it with a lot of the data that Bree showed, is if they're predominantly using a methamphetamine-based product, it's pretty much methamphetamine. If they're using an unknown white powder, brown powder, purple powder, yellow powder, it could be almost anything. And so then you don't really know from a individual standpoint, what they took, because they don't know what they took. So then what you're treating could be a variety of things. And so it really is helping us answer some of the questions that we've come across through Mendoza. And then site to site, this is why we want to expand Mendoza and we want to expand these sites, is you see regional differences, right? So the more we can get coverage better throughout the state through Mendoza, and then even then more coverage throughout the state with harm reduction sites or law enforcement agencies helping us, we build a better picture to answer those questions and get better treatment options for people.
And I think In addition to, so you're getting lab samples, the MDH is going back and getting information from the patient's record. So is the metomidine, was that dexmedetomidine that was administered in the hospital? Can you at least check it off and say, oh, they got some? But all said and done, the amount of work for an emergency department is, I think, and having been there from the beginning and in the ED, it's minimal. Somebody needs to enter the patient. The stuff goes off to the lab. It's all built on the back end. A lot of the work is done by the Department of Health. Again, the case record reviews, as long as they get those samples with some identifiers, they're doing a ton of the work.
Yeah, the most important part is identifying the cases. So, as you know, the hospital retention time for samples is very short, so as long as those cases can be identified, in that first 24 hours, the lab just needs to flag it. It doesn't need to come to us that quickly. It just needs to be flagged and stored. And then if we get it, the next day or 2 weeks, a month later, it doesn't make a difference, So it's just really that, awareness of, hey, we had this overdose, we had this case, this was kind of unusual. There were clinical samples taken, let's flag those. And then we could work out all the details on how to get them to us and everything later.
Any other questions before we wrap up today's session?
I think we've got them all.
All right. Well, thank you so much for presenting for us today. That was wonderful.
Thanks for having us. I provided slides out. Feel free to distribute those, and our contact information's on there to reach out for samples, for questions, for more information. We're available. So thanks for all your time.
Hey, thank you very much.
I appreciate the time.